Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your host for this cardiovascular series. Today we're diving into pericardial disease, specifically pericarditis and pericardial effusion. These conditions are commonly encountered in primary care and emergency settings, and recognizing them early can prevent severe complications, including cardiac tamponade. We'll go over the basics of pericardial anatomy, pathophysiology, key clinical presentations, diagnosis, and management so you can confidently assess and treat these conditions. Plus, we'll share some clinical pearls and, of course, test your knowledge with clinical cases at the end. Let's get started. Starting off with some basic pathophysiology, the pericardium is a fibroelastic sac that surrounds the heart and normally contains 15 to 50 milliliters of lubricating fluid. Pericarditis is inflammation of the pericardium, often leading to excess fluid production. A pericardial effusion is considered to be present when accumulated fluid within the sac exceeds the small physiologic amount of 15 to 50 milliliters. Pericarditis can be idiopathic or secondary to infections, autoimmune diseases, malignancies, or post-myocardial infarction syndromes called Dressler syndrome. Most cases are viral in origin, most commonly due to Coxsackie virus or echovirus. Pericardial effusion is a common manifestation of pericarditis and can develop from any of the acute pericarditis processes. Now, who is affected? Pericarditis can occur at any age, but it's more common in male adults and often preceded by a viral upper respiratory infection by about 1 to 2 weeks. Regarding clinical presentation, acute pericarditis can present with a variety of nonspecific signs and symptoms, depending on the underlying etiology. To remember the major clinical manifestations of acute pericarditis, you can think of the 3 Ps: pleuritic, positional, and pericardial friction rub. Patients will usually have pleuritic chest pain, which is sharp pain that worsens with inspiration. They may have positional relief, which means their pain will improve when sitting up and leaning forward, but worsens when lying supine. And you may hear a pericardial friction rub, which is a superficial scratchy or squeaking sound best heard at the left sternal border. Pericardial friction rubs are often intermittent, with an intensity that tends to wax and wane, and are best heard using the diaphragm of the stethoscope. Now, if you want to add a 4th P to the 3 Ps that we already discussed, you can add pericardial effusion. This is a common feature of pericarditis, but is not required for diagnosis. Usually, there are no symptoms specific to the effusion, and symptoms may be related to the underlying condition, such as infection, uremia, or autoimmune disease. The diagnosis of acute pericarditis can be made by the presence of at least 2 of the following 4 criteria. Number 1 is the typical chest pain, sharp and pleuritic, improved by sitting up and leaning forward. Number 2 is the pericardial friction rub. Like we said, this is a superficial, scratchy, or squeaking sound best heard with the diaphragm of the stethoscope over the left sternal border. Number 3 are characteristic changes on the EKG, which would be classic diffuse ST elevations with PR depressions, especially in the limb leads. And number 4 is new or worsening pericardial effusion. For all patients with suspected acute pericarditis, the initial evaluation includes a comprehensive history and physical exam, selective blood work assessing for markers of inflammation and myocardial damage. This would be a CBC, troponin, erythrocyte sedimentation rate, and C-reactive protein. In addition, you would want to order a chest radiograph, electrocardiogram, and echocardiogram. The chest radiograph and echocardiogram would usually be normal unless there's an associated effusion, and you could expect to find leukocytosis and elevation in the inflammatory markers on your blood work. Regarding a pericardial effusion, on chest radiograph, this may show enlargement of the cardiac silhouette. This usually occurs when greater than 250 milliliters of fluid has accumulated and can take on a water bottle shape if large. but in cases where there's low fluid accumulation, the chest X-ray might appear normal. The EKG may show low voltage QRS, sinus tachycardia, or diffuse ST elevation with PR depression like in pericarditis. Electrical alternans, which is beat-to-beat alternating amplitude of the QRS complexes, can be seen in pericardial effusion or cardiac tamponade, and this reflects swinging of the heart in the pericardial fluid. And lastly, an echocardiogram is considered gold standard for detecting effusions, determining size, and assessing for tamponade. Moving on to the management. For pericarditis, the first line is a combination of an NSAID with colchicine. This is generally ibuprofen or aspirin plus the colchicine. An acceptable alternative is indomethacin plus colchicine in cases that are poorly responsive to ibuprofen or aspirin. In cases of pericarditis due to identifiable causes other than viral infection, such as bacterial infection or malignancy, management is focused upon the underlying disorder, and, if necessary, drainage of an associated pericardial effusion. In addition, glucocorticoids are used for initial treatment of acute pericarditis only in patients with contraindications to NSAIDs. Examples are renal failure or pregnancy at greater than or equal to 20 weeks gestation, or for specific indications like systemic inflammatory diseases, and should be used at the lowest effective dose. The latter recommendation results from the greater likelihood of recurrent pericarditis when glucocorticoid therapy is used early in the course of the disease, along with a number of potentially significant side effects of systemic glucocorticoid therapy. Patients will also need to restrict their activity. Strenuous physical activity may trigger recurrence of symptoms. Therefore, such activity should be avoided until symptom resolution and normalization of biomarkers. And now let's discuss the management of a pericardial effusion. This depends on the patient's stability and the underlying cause of the effusion. Identify and treat the underlying conditions. For small effusions in a stable patient, these are usually self-resolving and typically don't need any intervention. Observation and serial echocardiograms are indicated in these cases. Cases in which pericardial drainage can be considered would be large symptomatic effusions, effusions with an uncertain etiology, purulent pericarditis, or in cases of cardiac tamponade, which we'll talk about a little bit more in a separate podcast. Regarding prevention, you can't always prevent pericarditis and pericardial effusion, but you can reduce the risk by avoiding infections, getting vaccinations such as influenza and COVID-19, seeking prompt treatment for infections, treating underlying conditions like malignancy or autoimmune disorders like rheumatoid arthritis or lupus, and practicing good hand hygiene. Here are a couple of clinical pearls. Number 1. Cardiac tamponade is a medical emergency. You want to think about Beck's triad, which is hypotension, jugular venous distension, and muffled heart sounds. If you suspect it, don't delay pericardiocentesis. Check out the podcast specific for cardiac tamponade for more information. And number 2, pericardial rubs are intermittent. They tend to vary in intensity and can come and go over a period of hours. Therefore, you may need to auscultate frequently to hear it. All right, let's practice some questions. Question 1. A 28-year-old man presents to the clinic with a sharp pleuritic chest pain that worsens when lying flat and improves when sitting up. He had a viral upper respiratory infection 1 week ago. On auscultation, you hear a pericardial friction rub. Electrocardiogram reveals diffuse ST segment elevations without reciprocal changes. Which of the following is the most likely diagnosis? Is it A, acute pericarditis, B, acute coronary syndrome, C, pulmonary embolism, or D, aortic dissection? I'll give you a couple of seconds. If you chose A, acute pericarditis, you are correct. The patient presents with classic features of acute pericarditis: pleuritic chest pain relieved by sitting up, a pericardial friction rub, and diffuse ST segment elevations on EKG. Acute coronary syndrome typically presents with localized ST elevations and reciprocal changes. Pulmonary embolism may cause pleuritic pain, but it is usually associated with tachypnea, tachycardia, and an S1Q3T3 pattern on electrocardiogram. And aortic dissection presents with tearing chest pain that radiates to the back and can sometimes present with asymmetric pulses. Question 2. A 30-year-old man presents with pleuritic chest pain that improves when sitting forward. He had a recent URI. On exam, you hear a pericardial friction rub. His EKG shows diffuse ST elevations and PR depressions. Which of the following is the next best step in management? Is it A, start aspirin and colchicine, B, perform an emergent pericardiocentesis, C, start IV heparin, or D, order a CT angiogram? If you chose A, start aspirin and colchicine, you are correct. This is acute pericarditis, likely viral in origin. NSAIDs plus colchicine are first line. Great job! Thanks for tuning in to this episode of the ProPA podcast. Pericarditis and pericardial effusion are conditions that require early recognition to avoid complications like cardiac tamponade. Don't forget to subscribe and follow for more episodes covering high-yield cardiovascular topics. And as always, this is the ProPA podcast, where future pros in medicine are made. See you next time.